Perfect. And with that, I will hand things over to Joel, Karen, Dr. Keogh, and Praveen.
All right, well, thank you, Patrick. And next slide, please.
Do you see it okay?
Yeah, I can see it now. Yes,
okay,
absolutely.
good.
Good afternoon, everyone. I'm Praveen Pant. I'm the Vice President of Advanced Analytics at ZeOmega. And today I'll be the moderator for this webinar. I have with me, in our today's agenda, we'll talk about 4 different things. We will first examine the SDOH complexities and recommendation on how to improve the data integration. We'll also discuss on what are some of the SDOH factors we should really focus on. We'll also talk on how to properly incorporate several important SDOH data at the right time so that it can improve the individual's overall health. And lastly, we'll also talk about how to leverage the right technology to effectively identify SDOH data for improving overall health and equity. With that being said, let's go to the next slide. And again, I have here with me Dr. William Keogh. He is the Senior Director of Utilization Management, WellSense. Joel Gurin, President and Founder of Code. Karen Iaposi, and she's the Senior Director of Government Solution at ZeOmega. And myself, I'm Praveen Pant, I'm the Vice President of Advanced Analytics. So this slide, basically, the social determinants of health can account for up to 80% of outcomes, and not all the information is obtained through a member's documented experience. So Joel, I know your organization has been doing a lot of work with the Department of Health and Human Services and also with ZeOmega on the use of data on social determinants of health. Can you talk a bit about why these organizations are seeing the SDOH as so important and the kinds of work that you have done?
Sure, I'd be happy to, Praveen. And let me just start and take a minute just to talk about our organization and who we are. So CODE stands for Center for Open Data Enterprise. We're a nonprofit based in Washington, D.C. that was founded in 2015 to maximize the value of open and shared data for the public good. So we're really very much about using public data and other kinds of widely available data to address public health issues, as well as many other kinds of issues also. We've done a lot of work recently, both with ZeOmega, with the Department of Health and Human Services, and others around SDOH and the use of SDOH data. And this slide, which comes from a report that we did with ZeOmega, actually, I think helps make the case not only for why SDOH data is important, but why some of the public sources of SDOH data can be so valuable. I mean, if you look at this breakdown, and there's a kind of common number now that maybe 80% of health outcomes could be due to social determinants of health. If you look at those top 2 numbers that add up to 50%, those are all really related to zip code and to readily available information that can be taken from public sources and combined with patient data and other kinds of clinical data and medical data to really get an accurate picture of an individual's or a community's risks relevant to social determinants. So we've been seeing really tremendous opportunity and need to use all kinds of data sources, including these public sources, for applying insights into the SDOH to better clinical care.
Well, thank you, Joel. So understanding that capturing data is a key component to identifying a population in social care. Again, Joel, what are some of the ways you have found SDOH data is important and some of the recommendations on proving it?
Sure. So I'd be happy to share that, and to let you all know that URL at the top, opendataenterprise.org/publications, is where you can find all of these reports that I'm going to talk about briefly. And these are all, a lot of the work that we do is through roundtables, where we'll bring together 70 or 80 experts from government, from nonprofits, from the private sector to talk about some of these major public data issues. And between that and other research that we've done with our partners, we've put out a number of reports around the uses of SDOH data and recommendations for improving the use. So the first three that you see on the left are all from projects that we did in partnership with the Department, excuse me, of Health and Human Services. So the first one, which goes back to the end of 2019, was on just generally on leveraging data on the social determinants of health and looking particularly at how to deal with issues. Oops, sorry, let's stay on that for a minute. Deal with issues around data sharing, privacy, and so on. We then moved on in 2020 to do a report specifically focused on the relationship of SDOH data to COVID risk and vulnerability and treatment. I'm sorry, could we get that slide back? Yeah, let's stay on that one if we could, please. Yeah. So this was a chance to look at different kinds of approaches and tools like Healthy People 2030, like the CDC's Social Vulnerability Index, and begin to look at what were some of the factors that were affecting the pandemic particularly. And coming out of that, we did our third program with HHS last year and published the results early this year that looked at what they were calling a cross-sectoral analysis, because what they were very interested in and what we see really across the board is a greater and greater understanding that looking at the social determinants and looking at that kind of data really requires an approach across sectors. So in a government context, for example, this cannot just be data that HHS has or that HHS uses. It also includes data from Department of Transportation or Department of Commerce or Housing and Urban Development and so on. So we've really begun to take an approach with HHS on how that could all come together. And then the final, the fourth piece that you see there is a very recent paper we've done with the IBM Center for the Business of Government on using data to address racial equity and in healthcare with the social determinants and social determinants data as a particularly important part of that. And then the final paper on the right is the one that we did with ZeOmega that I mentioned. So some of the recommendations and findings out of all this body of work are really around kind of the needs both for collecting, managing, presenting, disseminating SDOH data, and also making it useful and putting it to use. So a number of the common themes across all this work are the importance for better definitions and standards. Some of the work, for example, that the Gravity Project and others are doing to really get, kind of common definitions for what SDOH data is and what we're talking about here. A sustainable infrastructure for the data, both looking at how do we get some national, statistics that can be locally applicable, and also how to work with sorry, I'm still on that slide. Nope, I'm not on that one. That one. Yes, thank you. How do we also make it applicable at a state and local level? Improving data resources overall. And then this whole theme of kind of cross-sectoral collaboration. So at the federal level, HHS now has an SDOH working group where they're bringing in other agencies, but at a state and local level, looking at interrelationships between transportation departments, housing departments, health departments, food services, and so on, really becomes an argument for a more integrated approach that has sort of healthcare at the center, but really goes beyond it. So we're, and above, around all of this, the importance to look at these issues through an equity lens, and also around all of this, the importance to take a real community-focused approach and engage with communities in really meaningful ways. And I'll talk about that a little bit more later as well.
Thank you, Joel. That was a great, explanation there. So while we're just talking about the community and the data and then some of the recommendation, and Karen, how does census tract level data add value to identifying the needs of a family, and how can this be more effective in your opinion?
Sure, absolutely. Well, first, thank you, Joel. You've really set the stage for this webinar. So That's wonderful. And as we walk through, we'll start to tease out some more information. But at the community level, Praveen, the studies have shown that at a high quality of life is comprised of positive social determinants of health and a greater onset of health disparities manifesting within the community is comprised of multiple the negative social determinants of health. So we know that based on where the member is within the community and what their community data shows us is really going to give us the ability to see what is their potential outcome. And we have all of those studies, such as what Joel was just referencing, that give us that information about those members. But when it comes to our families, no matter how we define a family, they have a pivotal role in helping to maintain that structure for the child and for the pediatric and adolescent population. But identifying those social needs nested within the family structure may be a little bit of a challenge. And we'll have that discussion as we go through this webinar. But the census tract provides a quick visual that allows the entity that's interacting with the family the ability to ask about needs, about the social circle. And we do have to keep that in mind. The social circle is who are the people that we depend on, those individuals that we're having the conversation with. But we can do a lot more. And we'll start to have the conversation about interoperability with other platforms. And Joel referenced that when he was having his beginning opening remarks as well. And a full picture of the needs can be captured. We need to find some level of standardization, again, leaning back a little bit onto the Gravity Project as well. Looking at the way we're doing our assessments, the continuation of services. We'll probably have a little bit of a discussion today about budgets and what happens when budgets are cuts within states, and how do we make sure that we keep those services that are in place for those particular members as well. We need to begin to ask the questions, those really, really tough questions to the individuals in which we're serving. And also, as Dr. Kehoe will bring us through, to even the children, and to be able to take that data and gather all of those pieces of information to help foster trust and engagement. And then to look at those entities that are providing the services for the children. So we'll also start to touch base on the schools and food and security. And so we have all of these multiple data points, right? We have the community level data points that we were talking about that are sitting at the census level. And we also have all of these other pieces of data that we really need to then bring together to get a holistic picture of the individuals in which we're serving.
Thank you, Karen. Yeah, that's a very helpful insight. So our next slide, I think we're talking. Here's a table that's often used to describe SDOH. According to Kaiser Family Foundation, there are several SDOH factors which contribute to health outcomes. So Joel, my question to you is, what are some of the factors that you're seeing emerge as especially important in their impact to health?
Sure. So I would say, all of these factors, of course, are important, but one of the things I think that's really happened, at least in the work that we've seen and participated in around social determinants, is a real focus recently on what is related to the COVID pandemic and what are some of the factors that can help us both understand and address it. And looking at it through that lens, some interesting kind of priorities and interconnections sort of jump out. So if you look, for example, at the left, employment and income, I think are always, of course, just almost taken for granted as impacting health in a number of ways. But employment, as we've seen during COVID, is not just about the kind of money that you make, but also about conditions of employment, right? So for example, people who were, service workers who were not able to take sick days and so on, were more vulnerable, not just because of what they were being paid, but because of the way that their work was structured. Housing and transportation have, been shown to have a lot of impact on infectious diseases like this, when, people who are unhoused on one end of the spectrum, or people who are living in very crowded housing on the other, people who may need to rely on public transportation for long trips in ways that, increase the risk of transmission. I think we are seeing, I know we're going to talk about this more, but everything related to hunger, food insecurity, as a huge problem and a huge kind of determinant. We're seeing under the community sector discrimination and stress, certainly related to some of the racial disparities that we're seeing, that we have seen in COVID, particularly early in the early days, and that we see with so many kinds of diseases. And then, of course, the healthcare system itself is kind of a mega variable. You know, I mean, I don't know to the degree to which it's a social determinant or even something more, but of course, huge issues there in the distribution of care and access to care and so forth.
Great. So, Dr. Keogh, based on what Joel just shared with us, how do you see this impacting the children's population?
Yeah, thanks, Previn and Karen and Joel. Really appreciate it. So just so folks know, I'm a pediatrician and pediatric infectious disease doc by clinical training, and work on the payer side on some of these issues, particularly in and around Medicaid. You know, I think the thing, and sometimes stating the obvious is, we have to state the obvious, is that children have no control over any of these factors in their lives. They are subject to the whims and of the decisions, good or bad, that the adults around them make. And so we need to keep that in mind, in that whenever we're designing these systems, that this vulnerable population can't speak for itself. And well, things like census tract data are important. Remember that certain children aren't going to be captured all the time in the census tract data, depending on when the census is performed relative to their birth. We have a limited amount of time to impact on a child's growth and development. So, you know, generally, you know, the studies more and more show that impacting in those first several crucial years of life on development are really important for setting a child up for success in adulthood, for however they define success in their life. And then, you know, I'm not the data analyst and policy driver and expert that Joel is and his group are. But what I can say from the individual perspective is that we need to talk about integration and scalability and sustainability in these types of things. We also then have to have the courage to ask when we're in those encounters, at least for those of us who are clinically active and when we have the captive audience, so to speak, is to be comfortable to ask the questions, to give space and comfort to our patients. And myself as a pediatrician, that means the child I'm taking care of, as well as the adult caregivers around them, and make them know that you're there as a partner with them to help try and solve the problems as best that you can. And that in that sustainability, sort of building out for practices for healthcare facilities, also partnering with schools and other agencies about how to make sure that sustainability is built in that individual plan for that particular patient, that particular child and their family.
Great. So next slide. There is a growing awareness that SDOH improves whole person care, lowers costs, and all some of these factors are very closely interconnected. So Joel, my question to you is, I know you found out in your work that the SDOH factors are very interrelated, and then that all of them affect food insecurity as well as healthcare. Could you talk a bit about those connections and how they affect those factors?
Sure. Thanks, Praveen. And this is really just kind of coming back and emphasizing some of what we were talking about a little bit before about the cross-sectoral approach. This diagram actually comes from that report that we did with Health and Human Services around a cross-sectoral approach to the SDOH. When we really, and you know, again, our view of this is really based on talking to a large group of experts through a roundtable, through interviews, through research, and so on. And what people kind of kept pointing out to us was the incredibly intricate ways in which these factors are connected. So to just give you a couple of examples, I mean, it's pretty clear, I think pretty intuitive that employment and economic stability are going to impact just about everything. They impact clearly, you know, access to healthcare, access to housing, access to education, types of transportation, and so on. But the arrows also go in, even though this is a very kind of metaphorical document. It's not a diagram. It's not meant to show, you know, really X leads to Y leads to Z. The arrows are meant to show that it's all interconnected. So at the same time, in the same way that employment and economic stability affect housing choices, housing costs also really affect economic status, and the location of housing affects your access to food. If you live in a food desert, that's obviously going to be a problem. It affects your access to transportation, and transportation in turn also incorporates or affects various employment options. So it's all incredibly interrelated. And what we did find also is that if you look at healthcare and food security, those are two factors that are really impacted by just about everything. In the same way that employment and economic stability impacts just about everything else, just about everything impacts food security or insecurity in healthcare. So, what it means really, I think, is that looking at ways to improve healthcare really has to involve this very cross-sectoral approach that really appreciates and takes into account all these kinds of interconnections, that you've got to work with agencies and nonprofits and advocates who are working on all these areas to really find improvements across the board. And also that food security, food insecurity, just emphasizes what a critically important and central issue that is as well.
Great. So, Dr. Keogh, since we're talking about these interconnected SDO data factors, how do you see some of those connections playing out in practice? And what does that tell us about how we can improve the lives of children?
Sure. Well, to Joel's point about some of these are all interconnected, obviously, and a kaleidoscope of factors. But it's not hard. I don't think anybody who you don't need a pediatrician to tell you that the developing brain needs adequate, healthy nutrition in order to achieve its full capacity. The growing body, additionally, all the other organs of the body, the bones, the heart, the lungs, they all need adequate nutrition. Part of also it is too, we have to start looking at this, at least from my perspective as a pediatrician, is that even though we all know raising a child in this country is expensive, we have to look at these we have to start looking at this as an investment in this human being's future, but also in the future of us as a society. Children eventually do, most of them, thankfully, grow up to be adults. And so we want to set them up for the best success that we can by investing early on. And again, it may sound trite, but Benjamin Franklin probably got it right that, an ounce of prevention is worth a pound of cure. Investing in healthy nutrition, teaching children and families how to source food appropriately, getting them to those excellent sources of nutritious, healthy, whole foods, helping them learn if they don't already, because in our society where many of us wind up moving away from extended family, there's not a lot of that just sort of general passing down of knowledge about how to prepare certain foods, how to prepare them in a healthy and economic way. I think these are all things that we have to continue to focus on. And then making sure, one of the things that we know in the pandemic is that preventative health care fell off a cliff for children and adults. And one of those things, and I do some work additionally with the American Academy of Pediatrics, one of the things that we've been focused on is this very serious decline in certain communities that was made worse by the pandemic of completing routine vaccinations for vaccine preventable diseases. And again, going back to understanding that vaccines are prevention, and that they prevent serious disease and serious complications from disease, as well as all these other things. So early childhood development, great nutrition, safe, secure, and stable housing. These are all investments. They're investments in human beings' future. They're investments in our future as a society. And I think Karen's probably, Karen, I think you're going to sort of talk about sort of how ZEO and the platforms that ZEO has can help sort of focus in on where these needs are in different communities.
Yes,
yeah, that was my next question to Karen. Since we're talking about SDO's factors, how they're connected and their value. So what are some of the SDO's factors that ZeOmega focuses on, Karen?
Sure. So thank you, Dr. Keough, and thank you, Praveen. I probably should have told the participants from the very beginning that I'm a registered nurse by trade. And so this is a population that I've worked with very heavily in the past. And so here at ZeOmega, what we do is within our platform, we do a few things. One is we look at our individuals at community level, then we gather all of that data and start to look at our individuals at a population and at a member level. But within our platform, we focus on the education, employment, food access and security, housing in the neighborhood, income and transportation. And then we also have the ability to layer over some of those points in which Dr. Keough was bringing up, which are some of the health and the behavioral health as well. So what you're able to do now is start to look at not only your community level data, the data that's beginning to be captured within the system, but any of those other outside sources that we receive within our Jiva platform, and start to layer that on to be able to get that full picture of what our next best actions are going to be for those particular, as I call them, the littles, right, for the children. But the true goal here is to provide our clients with the ability to have the insight at the community, at the population level, and at the member level. And then from there, provide the next best actions, and then allow our clients to, if they are connected with a CBRO, or if they are connected with any other entity, to send out any types of referrals and receive that closed loop back and start to begin to have engagement as well, right? So the key here is also when you're working with a population that already comes out of the gate, maybe having not trusting us as much, right? Because things ebb and flow, is to foster the trust and keep that continuation of care and services in place to help those little developing brains, right? And those little bodies grow.
Thank you, Karen. So next slide, please. We all know that children move between various households, and babies and children may bounce around, and plans can only go by the address given. So my question to Dr. Keough is, on what is the best approach to capture the SDO's data when there is a family or children moving from households, from one house to the other household?
Yeah, and I probably should have asked you not to ask me this question and setting me up for failure. I think if you ask a lot of pediatricians, you're going to get a lot of different answers. I think if you ask many in healthcare or who work in this population, I think you're going to get many different answers. And I appreciate, Pravin, you and Karen's and CEO's trust in me that somehow I would know the best answer for every situation. I think for me personally, and the folks that I work most closely with, I think it comes back to asking. And as Karen was referring to, is developing those individual relationships and the patient encounters we are supposed to do as doctors and nurses, and I'm sure anybody who is on the call already does. But building those relationships, building that trust, giving families the opportunity to express their concerns in a non-judgmental fashion, in a safe way, whether you want to call it a safe zone or the like, and that to not make assumptions about what's best for them and to really ask them what's best for them in their situation. And then, we need platforms to sort of feed back that information for folks like Joel and folks like you folks at ZEO about sort of how do we capture that information that those individuals to then translate that into what works, what's working, what's not working, what's working at the community level, what's working at a bigger population level. And so I think that's, along with lots of infrastructure we need to keep building and improving upon. I think that's one of the parts of infrastructure we need to keep building upon is how do we turn that individual, those individual needs, those individual ideas about what's best for these families and these individual patients back into good data that policymakers and the federal government, state governments, local governments in terms of fund and NGOs can use for where to set funding priorities.
Okay, great, thank you. So moving into the next slide, I want to talk a little bit about food insecurity. And again, going back to you, Dr. Keogh, I just want to take a few moments for us to discuss the food insecurity in children. When school is in session, children are receiving nutritious meals. Can you share with us your thoughts on this data?
So these are from these obviously aren't my data. These are from the USDA, who have a lot of data on the issue around food insecurity. Various of states have also state level data. It's not surprising that we still have way too many individuals and especially way too many children who are experiencing hunger and food insecurity in their lives. So the 2020 data you can see here, I'm not going to read all of it to you. I know everybody on the call can see graphs and understand. Too many children, 6.1 million, more than zero in this is probably a bad number. What's also not surprising and keeps getting demonstrated in every social determinant and just about everything in our society these days is that there are racial and ethnic disparities, and that the issues for non-whites, so households, Black households, Hispanic households, single family households, which are especially those led by a female head of household, all have higher rates than the national average. And so these are things that we need to focus on. There are now opportunities, however, to look at what's working and what's not going to work. We have experiments, the states being the laboratories of our democracy. California this school year is instituting statewide that all children in public schools in California will get a free breakfast and free lunch, is my understanding from the legislation. And then Maine has passed a similar law that I'm pretty sure, although if folks are from Maine and or California want to correct me if I'm wrong on any of this, Maine has passed a law to also provide free school lunches to all public school children in Maine. Different states on different sides of the country with different types of populations and population mixes in them. But herein is an opportunity to start looking at the data where we can really have an impact on really addressing something that in a country that throws away more food than it consumes, we probably can find a way to sort of better distribute to the maximal effect for everyone's benefit.
Great. Thank you there, Dr. Keogh. Again, this next slide, I will talk briefly about some multiple frameworks for children. As we know that there are a lot of frameworks that's related to social determinants of health. And in your opinion, Dr. Keogh, what are some of the few frameworks that is worth that's we can discuss it and we can really see which can have more impacts? So if you could really talk a little bit.
Sure. So we gave some examples up here. These are readily available online. Folks know sort of a lot of these organizations, or even the one senator named. The CDC, Boston Children's, a number of the other major children's centers in the country. So Children's of Philadelphia, Children's of Pittsburgh, quite a number of others. National Children's of DC. A number have these sort of frameworks about building community help and how that helps build healthy families and therefore healthy children who are successful adults. Obviously, something that I'm an organization I'm very passionate and involved with, the American Academy of Pediatrics, every couple of years publishes an update to its Blueprint for Children. They started this several cycles ago. AAP is a nonpartisan organization. It doesn't care which party you're in. It just asks that you pay attention to the needs of children. And again, it goes back to economic security, food security, health security, focusing on child development. Senator Casey from Pennsylvania has taken that and last year proposed akin to the famous FDR speech around freedoms. He's proposed these freedoms for children. So the freedom to be healthy, economically secure, learn, hunger, and be safe from harm as sort of national policy goals. Again, if you start to look at these and any of the ones that I've sort of mentioned that aren't sort of listed here, you start to see very large similarities between them and common themes. And so no matter where you come from it, if we focus on these types of issues for children, we build healthy children to become successful adults.
Great. Our next slide. So again, we all know that capturing a need of a child at every aspect is very important. So with that in mind, Dr. Keogh, what are some of the challenges for pediatricians when it comes to addressing these significant drivers of health outcomes in the clinical setting?
Time.
Okay.
Is one of the biggest, when in the context of a well-child visit, anyone who works in pediatrics is on the call. I don't need to tell them that. You're only usually allowed so much time per visit, trying to accomplish all the things that you have to do around just examining the child, development of the child, feeding, immunizations, screenings for developmental issues, for school, and then add in if the child also is sick at the same time, or one of the siblings is sick. Those are some of the things that are challenged. So to even be able to allow the space or have time to ask questions related to social determinants of health, despite the fact that I know the vast majority, if not all, pediatricians want to try and make sure that they're addressing these issues, it becomes a challenge. I think also too, for those who are, although whether or not you're in a large resource setting or those who are in individual or small group practices, knowing where the best resources for children and their families to address these needs, so housing or food or transfer, excuse me, apologies, is sometimes hard. And then being able to have the staff who can help you follow up on these things while you continue to see patients who need you to be seen by the doctor. I think those are sort of some of the constant challenges that every pediatric practice faces. And then also too, 45 to 50% of kids in this country receive some sort of support from Medicaid. Medicaid, as we all know, reimbursements for the same services in Medicare or in commercial insurance reimburses at a lot lower rate. For stability of pediatric practices to be able to do as much as they can for the children that they serve, I think that's also another issue that chronically comes up for pediatricians.
Great. So my next question is for Karen. So, again, how do you really identify the needs outside of clinical settings? What approaches, Karen, you think seems to help here?
Sure. So thanks, Praveen. So yeah, we had the conversation about what we're looking at in the clinical setting. And we do know that interoperability is huge in getting all of that information into and to be able to compile and get the full picture of the member and the children in which we're serving. But there's also other entities that are capturing those particular pieces of information that we also would like to receive as well. There's a lot of data regarding the needs for these children that are sitting in within school systems, within some of the Big Brothers Big Sisters, some of those other entities that are helping to support these children as they're navigating through the life cycle. So it's the ability for us to be able to ascertain all of that information as well and begin to layer that on and start to look at the needs of the children. There's also that question that we keep going back to, or the point that we keep going back to with Dr. Keogh. It's about fostering trust and the ability to be able to ask the questions through the life cycle of the child at different data points within their life, not just within the clinical setting as well. And then how do we get that information back in? I think the schools are filled with a high level of information that would be very helpful for pediatricians and for plans and for other entities that are managing. You can also talk about the churches and other support services as well.
Okay, great, thank you. Your next slide, please.
Sure thing. Here we go.
Thank you. So again, it is important for healthcare organizations to build a strong SDOH program, and there is strong evidence that investment in the earliest years can have very high impact on children's development and their ability to thrive and grow to be healthier adults. So my question to Dr. Keogh is, what programs do you find are needed to help build a pediatric SDOH program? And also, what are some of the steps that a healthcare organization should focus on and its approach?
So I think you need the data to show what's going on in your community. I think you need both the census, community, larger geographic area. I think you need reliable, sustainable sources of funding and human capital to run these programs. The last thing you want to do, particularly in the short lifespan that a child is a child, is to go in 1 year and do all this work to then have it not sustained and then lose ground the next year because of lack of funding sources. Again, I reference people to that there are people working on this daily from a research perspective at places like Boston Children's and the CDC and at the National American Academy of Pediatrics and other great institutions around the country. And I'm happy to put anybody in touch with any of them that you want to in terms of how to get these set up. But I think that's and then connecting the dots. I think that's also sort of is connecting the dots for the various organizations that are already there in the field doing the work. And asking them how they need to be best supported to continue to do the great work that they're doing.
Okay, great. So our next slide, I think we're talking about reducing it's about the COVID racial gap. So Joel, you've noted that COVID may be giving us a good example of how community-based programs can be effective. Can you tell us what we're seeing in the slide and how it relates to the other approaches to the community intervention? I think you're on mute.
I just saw that. I'm sorry. Yeah, and actually this slide and the next slide, I want to just come back, before we wrap up and take some questions. And I guess just reminding everybody that questions, can be put in the Q&A channel. Just wanted to come back to two kind of overall themes that we're seeing, both as they relate to kids, as Dr. Keogh has just been giving us a lot of depth around those issues, and also how they relate to SDOH factors in general. And the first one is really about community, and the second one on the next slide is about climate. So one of the things that we've sort of touched on in this webinar is the importance of community engagement around any kind of efforts to use SDOH information to drive or support improvements in services. And just want to call to everyone's attention this was actually from an article in the New York Times in June, that we have right now a very potentially hopeful example of kind of nationwide community intervention in COVID. And even though these numbers are mostly are for adults, I think the same kind of approach could apply as vaccines become more and more available for younger children. Essentially, what this is showing is that if you remember, particularly early in the pandemic, one of the major issues of concern was that the rates of deaths and hospitalizations from COVID for Black and Latino Americans was much, much higher than for white Americans. That racial gap has really diminished and actually to some degree reversed, where white Americans, if anything, are now having a somewhat higher rate of COVID deaths than Black and Latino Americans are, as well as the overall rate, hopefully starting to trend down. And what's interesting about this is that this appears to really have been the impact of very successful nationwide community intervention around vaccination in particular. One of the quotes from the Times articles, they say that one crucial feature of these community-based campaigns has been their bottom-up nature. Local leaders have designed outreach campaigns to fit their own communities, whether through churches, through community-based organizations and other kinds of ways. And that this has also been really important in gaining the trust of community members who, like many Americans, may have been vaccine skeptical. And the article also talks about how doctors and nurses have had to sort of answer vaccine skepticism and quote unquote listen with humility. So I just wanted to flag this as I think a very kind of valuable case study as we talk about community engagement, which is so much a part of all of these interventions we're talking about. And then the next slide, if we could just go to the next one, just wanted to raise something that we're seeing a lot in our work, which is that the traditional social determinants and that table from Kaiser really say very little about environmental factors on a large scale. And this is a piece actually from this comes from some of the publications. We've used this in a few of the publications that we put out recently, including the one on cross-sectoral SDOH approaches. But we're seeing, tremendous interactions between climate change and direct health threats, for example, through urban heat islands, where we're seeing in cities like Los Angeles that on a given day, a low-income neighborhood may be 10 or 15 degrees hotter than a rich neighborhood because of issues like tree cover and so on and so forth. And as we look into the future, the impact of climate change on food availability, on housing, on all kinds of factors is going to be huge. So just wanted to flag this as something that we see as a real emerging aspect of social determinants. There is an Office of Climate Change and Health Equity that's been started within Health and Human Services. They have not been funded yet. I think they may be under the new bill, but just flagging this as something that we think is going to be on the horizon as a bigger and bigger issue.
Great. Well, thank you. I think let's go to the next slide. And so my question to all is, what is one key takeaway when it comes to identifying the needs and able to deliver on those needs? So if we can quickly answer that to our audience, that would be great.
Each of us with a key takeaway?
Yes.
Okay.
Let's just make it quick so that we can take
I'll start. Everything is connected. And it's complicated, but it's solvable.
Karen?
I'm sorry, I have to agree with Joel. Everything is connected. We just need to make sure that we have some standardization and interoperability to make sure that we can connect all of those dots and drive next best action.
Right. Dr. Keogh?
Ditto.
Great. Well, with that being said, I think we are ready to go to our Q&A. Thank you, everyone. So let's.
Sure. You want to go to the next slide while the Q&A is up?
Yep, absolutely. Yep. So we can probably talk about this as well. So yeah, if you could elaborate a little bit on this approach, ZeOmega's approach to social care, Karen.
Sure. So, and it may help answer some of the questions that are sitting into the chat as well. So one of the questions we got into the chat was, other than the census data, how have you captured data and how do you capture data at a member level, which is some great questions. And we'll talk about that when we're talking about our social determinants of health platform. So we do multiple things within ZeOmega within our Jiva platform to capture data that sits at the community level all the way down to the member level data. So we have information that comes in from outside sources, as well as information that's driven through assessments as well, that help us then calculate what does our community level data look like versus our member level data. And we provide that information to our clients as that one-stop shopping, right? So they don't have to go and search to figure out, what do I need to talk? How do I need to start to engage with my member? What are those conversations that I need to have? Or what are the services that I need to put into place? If we cannot get our housing for the individual in which we're serving, how are we going to get them to take their medications, right? How are we going to get them to store their insulin? If they don't have a refrigerator, are we really smart and strategic about what type of food services we provide to the member? So within our platform, what you have the ability to do is see the full person, medical, behavioral, social care, and we start to be able to drive those risk factors and next best actions, and have the ability to close the loop. The beautiful thing about all of this is we're trying to make sure that the end user doesn't have to go searching so hard for all of that information that they need to drive the care for the individual or the families in which they're serving. So we provide our clients as well with a family link to be able to, because we understand if the parents or the grandparent or whomever is taking care of these littles is having a social risk, high likelihood, right? It's happening within the household as well. And just another little caveat that we really didn't talk about as we were doing this, I always say capturing an ROI with social determinants of health is like tacking Jello to a wall. It's pretty tough, right? And how do you define the ROI? Is the ROI from tracking that child from birth and all the interventions that were put into place and at the milestones of their life? Is the ROI knowing that you've decreased your readmission rates, you've increased medication adherence, you've put some community services into place to be able to prevent those food deserts because you've worked together with other entities? What you also want to be able to say is what we're putting into place, those best practices, and how do we track and how do we trend those as well.
Great. Well, thank you, Karen. I think that was very helpful and really definitely, I think, answered the question that we have on how do you, other than census data, what else do we capture?
Sure.
Do we have any other questions on the chat? Q&A? I don't see any.
We do not. There is still time for our attendees. Additionally, I'm sure our presenters would be happy to correspond with you offline. You can contact them directly, or I can hook you up as well, of course. Happy to do that.
And we did provide all of our attendees as we go through the slide deck, and if they request the slide deck, we have the references available. We also can provide our attendees with the information in the paper from Joel. We can pop that link into the chat as well. I'll get that link.
Perfect. Perfect. Yep. Okay, going once, going twice. We can go ahead and give you 5 minutes back. Okay, perfect. Well, I want to thank Dr. Kyo, Joel, Karen, Praveen. Thank you so much for this great presentation. There's a ton of useful information, so I know I'm glad I already have the PowerPoint because I'll definitely be reading back through it. So I also want to remind our attendees that this September in Phoenix, ZeOmega will be at our annual conference, MHPA 22. So that's a great time where you can chat with them about this or something else. But with that, I want to thank you all for attending, our presenters for providing this, and I want you all to have a great afternoon. Thank you so much. Bye-bye.
Thank you.
Thank you. Bye.
Thank you.